Welcome to this channel made for me. In this video, we will talk about the varicose vein in details. So let's start. So varicose vein. A vein is said to be varicose only when it is dilated, elongated, and tortuous. So a vein is said to be varicose only when it is dilated, elongated, and tortuous. So, what are the sites which are very prone for the formation of this varicose vein? Then the most common site is the lower limb. The most common site is the lower limb. Uh, is only lower limb uh, uh, there is a formation of varicose vein? No, there are other sites also, like pempiniform plexus of like pempiniform plexus of veins. Where it is found in spermatic cord. Okay, it is found in spermatic cord. And what are the other sites? It can also be present in vulva, perineum. So these are the sites where varicose vein can be formed. Now let's talk that why this lower limb is more responsible for the formation of varicose vein rather than upper limb. So at first we have to know the anatomy of the upper limb and lower limb. In upper limb, the venous drainage. In upper limb, the venous drainage is mostly 20% only by superficial veins. 20% only by superficial veins. But in uh, but 80% is by deep veins. 80% is by deep veins. But in case of lower limb, the venous drainage by superficial vein is around 80% and by deep veins is around 20%. So it is totally opposite to that of upper limb. Okay. And in case of this upper limb, the most of the time the veins are usually above the level of heart. So veins are above level of heart most of the time. uh, do you think that in lower limb also these veins are above the level of heart? No, they are always below the level of heart most of the time. So they are more prone for the increased risk of venous hypertension. Okay. And the third point is that in the lower limb there are more perforators. And there are more valve there are more valves present in the lower limb. Okay. But in case of upper limb, there are no name perforators might be present here, but there are no name perforators. But in case of lower limb, there are name perforators like Hunterian, Doid, Boyd, we'll talk later. But in case of upper limb, there are no name perforators and there are no valves in the veins. Okay. But in case of lower limb, there are more perforators, more valve, and the superficial venous drainage system is present in case of lower limb. So the chance of formation of varicose vein is more in lower limb. Okay. Did you get this? This question has been asked in the viva by external to me, and I have answered this. Now again, the what external ask is that can varicose vein occur in upper limb? Yes, it can occur. Okay. So can varicose occur in upper limb? Yes, of course, but very rarely. Yes, but rarely. When does this happens? In case of SVC syndrome, superior vena cava syndrome, varicose vein can occur in upper limb also. So in case of SVC syndrome, This thing we have to know. Now let's talk about the drainage system in the lower limb. So first, imagine this is the structure of leg, okay, and this is the deep vein. This is the deep vein. So deep vein, I will write as this is the anterior tibial, okay. This is the posterior tibial, and this is the peroneal. These are the three vein. So anterior tibial, posterior tibial, and peroneal vein. Peroneal vein. These three vein go above and form the popliteal vein, and then again it forms into the femoral vein. Okay. So in this way, the formation of vein occurs in the deep vein. Now let's talk about the superficial veins. So there is one greater saphenous vein. There is one greater saphenous vein which arise from, I will say that first row. This is the greater saphenous vein which um, join the femoral vein at saphenofemoral junction. Okay, and here is one short saphenous vein. So short saphenous vein join the popliteal vein at 2 to 15 centimeter from the knee joint line. That is not necessary. Only what we have to know that this great saphenous vein, this great saphenous vein, I simply write as great saphenous vein. This great saphenous vein join the femoral vein at saphenofemoral junction, and this is the short saphenous vein, which join the popliteal vein. Short saphenous vein which join the popliteal vein. Okay. Now this great saphenous vein, where does it starts from? So great saphenous vein, it starts from medial side of dorsal venous arc. Medial side of dorsal venous arc. And this short saphenous vein, it starts from the lateral side of dorsal venous arc. The lateral side of dorsal venous arc. Okay. Now after starting from this medial side of dorsal venous arc, this greater saphenous vein, it runs in front of the medial malleolus. Okay, then it runs in front of medial malleolus. Similarly, this short saphenous vein, it runs in front of lateral malleolus. So from this, what we know that if this great saphenous vein is involved, then there will be pigmentation, there will be ulcer formation. If it is not treated, it will form in the medial side. It will be formed in the medial side of the leg, which is also known as the gaiter zone. Which zone? Gaiter zone. Do you know what is this gaiter zone? So the army police, they used to put the socks. This gaiter zone, it begins from the level of ankle to the mid calf. Okay, so this area has to be protected by this army. In order to prevent from mud, dust, or from animal bites. Okay, so this varicose ulcer, if it is present in the great saphenous vein, okay, if this great saphenous vein is involved, then this gaiter zone, the zone where we wear the socks, this area get involved. Okay, so we have to know that. Now let's talk about the perforators. So there are around 150 perforators in our body. Okay, there are around 150 perforators in our body, but we have to know a few. So at first there is one perforator which is at the level of adductor canal. Okay, let's simplify. uh, this area is the femoral vein, and this one is the popliteal vein. Here at the level of this femoral vein there is one perforator. Okay, this is the perforator which join to the great saphenous vein. Okay, and there is one perforator at the level of popliteal vein which join with this great saphenous vein. Okay, and this is the at the level above knee. Okay, if this is the area of knee, then this perforator is above knee, and there is again one perforator which is below the level of knee, Okay, so these become three perforators. Now one is the lower leg perforators. Okay, one is the lower leg perforators one is lower leg perforators, and another is the ankle perforator. So there are five perforator which we have to know. So one is which perforator? It is named as anterior perforator. Okay, the second one is above knee perforator. This is above knee perforator. And one is below knee perforator. The fourth one is the leg perforator. Lower leg perforator. Okay, and the last one is ankle perforator. Likewise, the anterior perforator is named. This above knee perforator is also named as door perforator, door perforator, and this below knee perforator is void perforator, and this lower leg perforator is named as cocket perforator. Okay, and the last one is the ankle knee perforator. Okay, it is also named as May or Kushner perforator. Okay, let's simplify. We can also remember this perforator named as like A, B, C, D, H. Okay, so the first one is A, ankle perforator. Okay, the first one is ankle perforator. The second one is board. The third one is void. Third one is dode, and okay, this dode, and H means anterior. So in this way we can remember. So A for ankle perforator, B for board, C for cocket, and D for doid, and S for anterior. Sometimes we forget that which one is above knee and which one is below knee. So the below knee perforator is void perforator, B for B. Okay, so after knowing this anatomy, what we have to know that what is the location of this saphenofemoral junction. Okay, so the location of saphenofemoral junction is that it is 4 centimeter lateral and below, 4 centimeter lateral and below to pubic tubercle. We have to know this. Now let's discuss that what I have told earlier. In lower limb the venous drainage is 80% by the superficial veins. Okay, so what are the superficial veins? They are the they are the great saphenous vein and short saphenous vein. They are the superficial veins. So these superficial veins, what they do? They drain the blood from the lower limb and they put it into the femoral vein. Okay, at the level of saphenofemoral junction, and the amount of blood which this great saphenous vein cannot put back into the venous system, what it do, it pump the blood through the perforators into the femoral vein. But when there is the pathology at the saphenofemoral junction, or when there is pathology at the perforator level, okay, there is pathology at the perforator level, then in spite of uh, in spite of pushing back the blood from the great saphenous vein and short saphenous vein into femoral vein and popliteal vein, what happens, the amount of blood which is present, in this femoral vein and popliteal vein, they start to get out of the femoral vein into the through the saphenofemoral junction into the great saphenous vein. And if the perforator is damaged, then actually the blood goes this way, but when there is perforator incompetence, this blood start to go in the opposite direction. Okay, these perforator are actually the one-way valve. Okay, they act like one-way valve, and when this valve get disturbed, or when it get damaged, when perforator gets damaged, there is reversal flow of the blood. Okay, then the blood starts to go in the opposite direction, and then this leads to the formation of this when initially this vein is normal, then this lead to the distension of the vein. When this vein distend, then it start forming the dilatation, tortuosity. Okay, and it becomes elongated, which we are supposed to known as the varicose vein. Okay, did you understand this? Now I want to know you one more thing, is that uh, to know the mechanism of heart. Okay, so this heart receive the blood from inferior vena cava. Okay, superior vena cava and inferior vena cava. Actually, the pressure in this lower limb is around 100 mmHg. Okay, around 100 mmHg, and in order to push more amount of blood to the heart, this pressure need to be overcome. Okay, so our body has a special mechanism. What it is that these valves, these veins are surrounded by the strong muscles. Okay, these veins are surrounded by the strong muscles, and when we walk, or when we contract the leg muscles, the leg when we contract the leg, this muscles gets contracted, and this leads to the compression of this vein, and the blood which is within the vein, it is pushed upward. Okay, it is pushed upward, and the vein also contains the valves, and this valve act as one way valve. Okay, and this vein act as one way valve, so they prevent the blood from getting downward. Okay, so this one, for the first one is the muscles around the leg, they contract, and this lead to the compression of these veins, and due to which the blood is pushed upward. And the second one is there is one way valve which prevent the backward flow of the blood. And the third one is that when the contraction is over, then what happens, these muscles start relaxing, so due to this, the pressure within the vein again decreases, and due to the decreased pressure, there is sucking of veins from this superficial veins into the deep veins to refill the blood. Okay, so during the decrease of pressure, the blood from the superficial vein is gets sucked into this deep veins. Okay, so these are the three mechanisms due to which the pressure, this 100 mmHg, is reduced to 30 mmHg. This 100 mmHg is reduced to 30 mmHg, and this theory is known as calf pump mechanism. Okay, this is calf pump mechanism. So in this way, the pressure 100 mmHg is reduced to 30 mmHg in case of normal person. But when the mechanism of this valve disturbed, okay, then this 100 mmHg pressure do not decrease to 30 mmHg, and it leads to the chronic ambulatory venous hypertension. We are discussing about this now. Let's talk about the pathophysiology of varicose vein. So in pathophysiology, there are two hypotheses. One is the fibrin cough theory. One is fibrin cough theory, and the another one is the white cell trapping theory. White cell trapping theory. In the fibrin cough theory, there is incompetence of the venous valves. I have already told that when this venous valve get incompetent, there is reversal of the blood flow. Okay, so at first there is incompetence. There is incompetence of venous valve. What does it do? It leads to the stasis. It leads to the stasis of blood. Leads to the stasis of blood. When this blood get accumulated, and like this is the vein. When this blood get accumulated in the vein, then it causes the chronic ambulatory venous hypertension. What does it cause? It causes chronic ambulatory venous hypertension. Chronic ambulatory venous hypertension. When the pressure in the venous system is increased, it causes the blood to diffuse into the tissue planes. It causes the first it causes the defective microcirculation. Okay, and later on the RBC get diffused. This RBC get diffused into the tissue planes. Okay, this RBC get diffused into tissue plane. Gets diffused into tissue planes. When this RBC gets diffused into tissue planes, we know that this varicose vein is occurring most commonly in the great saphenous vein. Okay, so in great saphenous vein, it lies medial to the medial malleolus. Okay, so at the region of this medial malleolus, okay, there is a very high pressure. So due to the high pressure, this RBC get ruptured. Okay, so first write like medial malleolus. Medial malleolus is under high pressure. Is under high pressure due to which this RBC get ruptured. RBC get ruptured. When this RBC gets ruptured, it forms pigments. Okay, there is the release of pigments, like the one is biliverdin is released. Okay, the biliverdin is released. This biliverdin causes itching. This biliverdin causes itching. And the second pigment which is released, it is hemosiderin. Hemosiderin. And this hemosiderin lead to the pigmentation. Lead to the pigmentation. Later on, it can cause the dermatitis. And it leads to the endothelial damage. When there is dermatitis, inflammation, then there start occurring the capillary endothelial damage, which lead to the prevention of diffusion and exchange of nutrition, okay, in between the cells and tissues. Okay, due to which there is severe anoxia. And if there is less supply of oxygen, then there can be chronic venous ulceration. Ulcer can be formed. And similarly, after a long time, the fibrin will start to get fibrin deposition. Okay, fibrin start to get deposit, and this lead to the sclerosis. So this is the fibrin cough theory. Now talking about white cell trapping theory. In white cell trapping theory, it is already saying that the white cell is trapped. So the WBC is trapped. When this WBC get trapped, it start releasing the proteolytic enzymes. Okay, it start the proteolytic enzymes which are already present there, they get activated. Okay, so inappropriate activation. So activation of inappropriate activation of proteolytic enzymes. Proteolytic enzymes. When these proteolytic enzymes get activated, then it causes cell destruction. Okay, then it causes cell destruction. And finally, what happens? There is fibrin deposition. Fibrin deposition. Okay, there is tissue death, fibrin deposition, tissue death, and scarring. And this all together, this 3 point, it is called as lipodermatosclerosis. Lipodermatosclerosis. Okay, so this is the pathophysiology of varicose vein. Now we have to know the classification, which is very important in case of varicose vein. Okay, so there is a very famous classification which is known as CEAP classification. CEAP classification. In CEAP classification, this C means it is clinical. C means it is clinical classification. So in clinical classification, what we see clinically, based on those points, the CAP classification C is made. Okay, so at first C0 means there is no signs of venous disease. There is no signs of venous disease. Okay, there is no signs of venous disease. And now in C1, there is formation of telangiectasia. Okay, telangiectasia or reticular veins. What does it mean? There is one important point. This telangiectasia means the veins which are dilated but which is less than 1 mm in diameter. And this reticular means the veins which are dilated but they are between 1 to 3 mm in diameter. Now you can guess that varicose vein is how much? So varicose vein is how much? More than 3 mm in diameter. Okay, so C1 is just telangiectasia or reticular veins. Now what is C2? I have already told that C2 is varicose vein which is of diameter more than 3 mm. Now C3 means how I recognize C3, that C3 we can write 3 like E. So E means edema. So C3 is edema. Now C4 has C4A, C4B and C4C. So C4A means pigmentation or eczema. And C4B is, it means lipodermatosclerosis. And C4C is corona phlebectasia. I will show you picture later on. And let's write C5. So C5 means it is the healed venous ulcer. And C6 is, it is active venous ulcer. So we can imagine the CEAP classification C part by just looking the clinical signs. Okay, so here we can see that at C0 there is no signs of venous disease, and C1 the diameter of vein, it is dilated but less than 1 mm or 1 to 3 mm. But in C2 it is varicose vein and it is more than 3 mm, and C3 means edema, C4A means pigmentation or eczema, B means lipodermatosclerosis. I want to make you know that in case of lipodermatosclerosis, what happens? The fat get obliterated, so there is woody film. Okay, the fats get obliterated, and there is a woody film. There is woody film. This woody film, mm, this woody film, it signifies that due to the obliteration of the fat, there is contraction of tendoachilles. There is contraction of tendoachilles, and due to the contraction of tendoachilles, the shape of leg looks like this. The shape of leg looks like this. So it looks like champagne. Okay, so it is known as champagne bottle appearance. Champagne bottle appearance. Why it is? It is due to the contraction of tendoachilles. Why? Due to obliteration of fat. Okay, so this champagne bottle appearance point is important. And this corona phylacteria, it means that corona phylacteria means that it is a fan-shaped pattern of telangiectasia. It is also a telangiectasia, but it is fan-shaped pattern of fan-shaped pattern of telangiectasia. Where? At ankle of foot. Where? At ankle or foot. This is a picture from our belly and loft. Here we can see that these are the small thread veins. Okay, these are small thread veins less than 1 mm in diameter, and we can see that these veins are dilated more, and it looks like between 2 mm in diameter. So it is uh, reticular veins, and here we can see that there is the formation of there is scarring. Okay, and there is it looks like there is deposition of fat. Okay, and there are sclerosis, so it is the lipodermatosclerosis. And here we can see that there is the pigmentation. Okay, pigmentation, which is due to the hemocysteine deposition, and there is mild eczema. Okay, this is the severe eczema. So by looking at this, we can just remember the clinical classification. Now it's time for etiological classification. So E means etiological classification. Etiological classification. So in etiological classification, uh, the first etiology is it can be either congenital, it can be either primary or secondary to any cause. Okay, so one is the congenital. So etiological congenital, it can be due to congenital. EC means congenital, and EP means primary cause, any primary cause. Okay, and then ES means secondary cause, and EN means the cause is not identified. Okay, in this way you can write the etiological classification. Now A means the anatomical classification. Anatomical classification. In anatomical classification, we just have to remember that which veins are involved. Which veins are involved. So in anatomical classification, A, S, either superficial veins are involved. One is the superficial vein. Okay, those are deep saphenous and short saphenous vein. And the second one is the P, perforator veins. And the third one is the AD, that is deep veins. And the fourth one is the no venous location is identified. Okay, so this is the anatomical classification. Now the last one is the P. The P means the pathophysiological classification. Pathophysiological classification. In pathophysiological classification, Either it can be due to reflux or it can be due to obstruction. Okay, so in pathological pathophysiological, the PR means due to any reflux, okay, and PO means due to any obstruction, and in PRO it means reflux plus obstruction, and if PN, then the no venous pathophysiology is identified. No venous pathophysiology identified. In this way, we can write the CEAP classification. Okay, now talking about its clinical features. So, do you think that the patient come in the very late stage? Yes, in patient like they from the far areas, they usually do not have any symptoms. They are asymptomatic, so they present only to the hospital when there is a formation of ulcer. So the patient can present it in the late stage also. So but when we write the clinical feature, we write like uh, most of the case it is asymptomatic. Most of the case it is asymptomatic, and there is just the cosmetic problem. Okay, there is cosmetic problem, asymptomatic or can be cosmetic problem. The second symptom is that there is the heaviness of leg. Okay, there is heaviness of leg. Patient feel very heavy. Patient feel very heavy uh, while walking up, while lying down. Okay, and then there is non-specific aching of leg. Non-specific aching. Non-specific aching of legs. Okay? And at night, what happens? They start cramping in the area of varicose vein. So there is a night cramping of leg. Night cramping of leg. And I have already told you that due to the deposition of pigments, there can be itching. Okay, there can be itching. There can be pigmentation. There can be itching, pigmentation. There can be edema. Later on, there can be venous ulcer formation. Venous ulcer formation, due to which there can be bleeding. There can be bleeding. Okay, and uh, when this venous ulcer is formed, it can lead to a lot of complications. Among them, the most major ones are, one is the margolin ulcer. The varicose venous ulcer can lead to the formation of margolin ulcer. The second one is periostitis tibia. Periostitis tibia. And the third one is the equinus deformity. Equinus deformity. So, in case of this varicose ulcer patient, the patient start walking on toes. Okay, the patient start walking on toes to relieve the symptom. So while walking on toes, it becomes a habit, and this lead to the shortening of tendons, and due to which there is the equinus deformity. Okay, and I forgot to mention one thing, that is the risk factor. So what type of patient are usually uh, 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 are prone to this varicose vein? So the first one is the any person, not patient, any person who have the habit of long standing, or who are supposed to stand for a long time due to their occupation. Okay, so any person who stands for long period. So what are those group of people who stand for long period? One is the army officer. They used to stand a lot. Okay, army officer. The second one is the surgeon. The surgeon, they used to stand a long, like 3 or 4 hours for surgery. Okay, the second one is surgeon. And the third one is the bus conductor, not bus driver. The bus conductor, they used to stand for a long period of time. So one risk factor is any person who stand for a long period of time. The second risk factor is the increasing age. The increasing age. Okay. The third one is the in comparison to the incidence of this varicose vein in male and female, the female are more common. The incidence of varicose vein is more common in female than in male. Okay. And the fourth one is the pregnancy. Okay. In case of pregnancy, there is the increased level in the progesterone hormone, and the increased level of progesterone hormone, it leads to the dilatation and relaxation of vein. Okay. Dilatation and relaxation of the vein of the lower limb, due to which there is more chance of formation of varicose vein. And the fifth person, uh, the person who are smokers. Okay. The person who smokes, and the person who suffers constipation, they used to they used to increase the abdominal pressure. Okay. While defecation, so due to which there can be chance of this varicose vein. So smokers, in patient with constipation patient, the incidence can be increased. Okay. And the person who is having the more BMI rate more, they are usually more prone in case of varicose vein. Now when patient present with the varicose vein, so we are supposed to do the clinical test. Okay, we are supposed to do clinical test, and this clinical test is very important in both the theory exam and viva exam. In my surgery examination, I was given a short case of varicose vein, and I was supposed to do the examination for varicose vein. So at first, after taking history, what are the tests which are necessary for varicose vein, I will list that, and I will explain in very short. We can see lots of video in YouTube, but I will just give a very short description. What are the tests and how it should be performed? So the first test is, we have to know that the incompetence is either on the saphenofemoral junction. Okay. Suppose this is the femoral vein, either this incompetence is in this saphenofemoral junction or in these perforators. We have to know that. So the first test which we do is for the saphenofemoral incompetence. Saphenofemoral incompetence. So what are the tests which we do for this? The first one is Trendelenburg test. Trendelenburg test. It is of two types. So Trendelenburg test type 1, and the second one is Morrissey cough impulse test. The third one is Schwartz test. So these three tests we do for the saphenofemoral incompetence, and for perforator incompetence, we do Trendelenburg test type 2. Trendelenburg test type 2. The second one is multiple tourniquet test. Multiple tourniquet test. And the third one is the Fagan test. So these three tests in each, they are important for the differentiation of which incompetency is present. In examination, our external part asks that give me one single test that can differentiate the which type of perforator or which type of incompetence is present in the patient. Only give one test. So most of the patient, most of the of our friends think that this Trendelenburg. Okay, most of the friends think about this Trendelenburg, and they told that the Trendelenburg test is important to differentiate the varicose vein for the incompetence, but they were scored very badly. The Trendelenburg test, it names so fancy, so we think that this is the single test which we have to do, but this is not. If the teacher asks about the single test, then we have to choose the multiple tourniquet test. Okay, we have to choose a multiple tourniquet test. And I was also asked that when this question was asked to me, I told that multiple tourniquet test is necessary to differentiate. Now teacher asked how many tourniquet do you need to test this incompetence. Then I accidentally said 3, and but the teacher told that 4 is necessary because there are one is Hunterian, Doet, Boet, ankle perforators. So 4 test is necessary to differentiate the incompetence. And the teacher was impressed. At least I could answer this multiple tourniquet test is the single test which is necessary. Now in this Trendelenburg test, what we do, we just listen. What we do, we ask the patient to lie down, and then we raise his leg to around 30 to 45 degree. And then when we raise leg, we just slide our fingers on his leg to draw the blood towards his body. Okay, so when all the veins were empty, then what we do, I press my the thumb at the saphenofemoral junction. Okay, I have already talked about the anatomy at the saphenofemoral junction. And then I ask the patient to raise out of the bed. Okay, to stand out of the bed. And while standing, there is 2 tests. One is the Trendelenburg test 1, and second one is the 2. So at 1, what I do, I have already pressed by thumb the saphenofemoral junction. Then I suddenly release that thumb. When accidentally the blood from the this femoral vein suddenly goes to the varicose vein, which were present early, then it makes me clear that there is saphenofemoral incompetence, due to which the blood which is not supposed to go in the reverse direction, but it has been going to the reverse direction. So there is saphenofemoral incompetence. But if that is not present, then again what I do, I ask the patient to lie down and raise his leg and empty the vein, and again I press at the saphenofemoral junction, and then again I make a patient stand out. After that, I do not relieve my hand. I do not release my hand from the saphenofemoral junction, and I wait for a few minutes to see that either the blood is feeding from below to upward, or there is nothing happening. If the blood is feeding from below to upward, then it means that there is perforator incompetence, due to the perforator incompetence, the blood is feeding from deep veins to the superficial veins. Okay, which is not supposed to. It was actually supposed to from superficial to deep, but here due to perforator incompetence, the blood is seemed to fill from the deep to superficial veins. Okay, and the varicose veins are filling. Now if this happens, if the superficial veins started to get filled, then I consider this Trendelenburg test 2 is positive. In this way, the Trendelenburg test 1 and 2 is done to differentiate the saphenofemoral incompetence and perforator incompetence. In case of Moises cough impulse test, what I do, I again ask the patient to lie down, and I elevate his leg and I empty the vein. Then I press the saphenofemoral junction with the thumb. Then I ask the patient to cough. If during coughing there is expansile impulse at my thumb, then it means that there is saphenofemoral incompetence. In this way, Morris's cough impulse test is done. And in case of Swartz test, I ask the patient to stand, and I press my thumb at the saphenofemoral junction. Okay, there is no need of emptying the veins. Okay, just ask the patient to stand and then press the thumb at the saphenofemoral junction, and then the varicose vein which we are seeing very distinctly, we just tap that varicose vein, tap tap. If we feel the impulse at the saphenofemoral junction with our thumb, then it means that the Swartz test is positive. Okay, in this way it is done. And in case of multiple tourniquet test, I have already told that to know the perforators, So one is at the saphenofemoral, below the saphenofemoral junction, and then above knee perforator, below knee perforator, leg perforator, ankle perforator. Okay, in this way, multiple tourniquets are bound in between these perforators. We need four. Okay, multiple tourniquet are tightened, and one uh, tourniquet is opened. And we know the level of perforator incompetence. And in case of Fagan test, what we do, we ask the patient to stand. Okay, the patient is stand, and then we mark the varicose, the areas where the varicose vein are more distinct. We mark that areas. Okay, we mark that areas with the pen, and then we ask the patient to lie down in a bed and elevate the leg to empty the veins. Okay, and after emptying, if we see the dimpling at that area where we marked the vein, or there is formation of pits. Okay, pits or gaps are filled in the deep fascia, then it shows that there is the incompetent perforators. Okay, in this way we do the saphenofemoral incompetence and perforator incompetence test. Now after doing this test, we move to the our investigation. So during investigation, the most important one is the duplex scan. Okay, the duplex scan, it is the investigation of choice. Okay, there are three types of scan. Okay, there are three types of scan. In duplex scan, we can see the blood flow direction plus velocity plus basal anatomy also. Okay, plus basal anatomy. So one is flow velocity, and another is the basal anatomy also. And in case of, there is also a name called triplex scan. Okay, so in triplex scan, there is this duplex scan plus collar doppler plus collar doppler. So what does it mean? That we can see the color coding also. We can see the color coding also in case of triplex scan. The first one is Doppler, where we can see only the blood flow direction velocity. Okay. The second one is duplex. Here we can see blood flow velocity along with basal anatomy, but we can see the color coding. But in case of triplex scan, we can see the color coding. So these are the three type of scan. Okay, which we usually do. But in case of this varicose vein, duplex scan is sufficient. Okay, so the first investigation what we do, it is that it is the duplex scan. The second investigation which we can do, but these are not necessary and these are not usually done nowadays. They are usually the venous Doppler. Yes, this Doppler, the venous Doppler. Other investigation, like we can do the venography. The fourth one is varicography. Okay, and if there is a formation of venous ulcer, then we can send the discharge now for the culture and sensitivity. Okay, discharge for culture and sensitivity for if there is presence of ulcer. And then so we can send biopsy if there is a formation of Marzollin's suspect of Marzolin also. Okay, and we can also send investigation like peripheral blood smear. Okay, platelet count, and then we can also send the random blood sugar. In this way, investigations can be done, but the most important investigation is duplex scan. Okay, now after doing investigation, yes, one thing is that during duplex scan, there is one sign which we can see during this duplex scan, and it has been asked in my viva. So what is the sign which we see in the duplex scan? So the first point is the Mickey Mouse sign. Okay, what is that? That is the Mickey Mouse sign. So what does it mean? What does it mean? It means that while doing duplex, we see the common femoral artery. Okay, the femoral artery, simply the femoral artery, and then we see the great saphenous vein, and we see a common femoral vein. Just simply we see femoral artery, femoral vein, and great saphenous vein, and this appearance looks like the Mickey Mouse. Okay, this doesn't looks like Mickey Mouse. Okay, this looks like Mickey Mouse. So during double scan, we see the Mickey Mouse sign in the transverse beam mode image of, this is the right side image, so it has been written right side, and it is uh, showing a Mickey Mouse sign where there is femoral artery, femoral vein, and great saphenous vein. So this is the Mickey Mouse sign. Now, regarding its management, uh, I will talk its management from the belly and loaf. So the first, when the patient present to the early stage, then there is just a symptomatic management. What we do, we give compression strokings. We give compression strokings. And according to British classification, there is three groups of stroking. There is like class 1, class 2, and class 3. Okay, class 1, class 2, and class 3. The class 1 provide around 14 to 17 mmHg pressure. Okay, and the class 2 provide 18 to 24 mmHg pressure, and then class 3 provides 25 to 55 mmHg pressure. Okay, so this compression stockings, they are worn during the daytime. Okay, they should be worn during the daytime, and these stockings do not treat the varicose vein, but it just relieve the symptoms. Okay, and it is done for for person who are not eligible for invasive procedures. Okay, so the first one is compression stocking. What we do, compression stockings we do. And the second one is, what we do, we can give injection sclerotherapy. Okay, we can give injection sclerotherapy. So in injection sclerotherapy examination, in examination, the teacher may ask which sclerotherapy is given. So the name of sclerotherapy is sodium tetradecyl sulfate. Sodium tetradecyl sulfate. We can easily remember as STD. Okay, STDs. Okay, so the injection sclerotherapy, we give sodium tetradecyl sulfate. But during this, what we do, we inject this STD into the superficial vein. Okay, into the superficial vein, that is great saphenous vein or short saphenous vein. When this is injected to the vein, what they do, they destroy the lipid membrane. Okay, they are actually the detergent, and they destroy the lipid membranes. They destroy lipid membranes of endothelial cells. They destroy lipid membranes of endothelial cells, and they lead to the formation of fibrosis. Okay, fibrosis, sclerosis, due to which there is a condition like glue attachment. The veins gets collapsed. Okay, the veins gets collapsed due to the fibrosis, and the varicosity is usually disappeared. So by this injection sclerotherapy is given. The disadvantage is that while giving this injection sclerotherapy STD, the blood deactivate this STD. Okay, this blood deactivate this STD, due to which more amount of STD is necessary to do the procedure, and at one time we cannot give a long dose of STD. Okay, so what we do, we prepare this STD in a pattern of foam. Okay, we prepare this STD in a pattern of foam where we mix this STD with air. Okay, and the foam sclerotherapy which we commonly use, it is the Tessari foam sclerotherapy. Tessari foam sclerotherapy. In this Tessari foam sclerotherapy, we use the two syringes. Okay, we will use a two syringes like this, and there is three-way valve. Okay, there is three-way valve. One valve is here, second one is here, and third one is here. So from one side we give the STD, and from next side we push the here. So we mix the sclerosant, that is STD, sclerosant and here in the ratio of 1:3 or 1:4. And after uh, vigorous cycles of pressing and compressing and releasing, okay, we get a foam, and this foam is just stable for only 2 minutes. Okay, and then after formation of foam, we inject this foam into the vein. Okay, and at one time it should not exceed more than 10 to 12 ml. Okay, so its amount is limited. So in this way the foam sclerotherapy is done. Now the third treatment which we can give, it is the endovenous glue. Endovenous glue. We use glue, okay, that just collapse these veins. So they are usually not used. So what at the recent time is done for varicose vein, it is the endothermal ablation. Okay, it is endothermal ablation. Endothermal ablation. Endothermal ablation, it can be done by two methods. One is laser method, laser ablation. Okay, one is laser ablation, and another is radio frequency ablation. Radio frequency ablation. This laser ablation is known as EVLA. EVLA. EVLA means endovenous laser ablation. Okay, and second was is the radio frequency ablation. Both of these methods have their own pros and cons. So according to the patient benefit and according to the patient choice and the doctor's experience, okay, and the doctor preference, these two types are used alternatively. And the fourth treatment what we do is the surgery. Okay, the surgery, there is two type of surgery. Okay, there is two pattern. The one is the Trendelenburg operation. Trendelenburg operation. Trendelenburg operation. Okay, in this Trendelenburg operation, what we do, we do the saphenofemoral junction ligation and greater saphenous stripping. What we do saphenofemoral junction ligation and greater saphenous stripping. What we do, we just ligate the this ligate this saphenofemoral junction, and we pull, and we then suddenly strip the vein, access vein, and then um, we make a suture. Okay, so here we do in Trendelenburg operation SF J ligation and greater saphenous stripping. Another method is it is the saphenopopliteal. Okay, the second one is saphenopopliteal. This is the saphenofemoral. Second one is saphenopopliteal junction ligation. Okay, the third one is we can also do Ceap's. There is one surgery known as Ceap's, subfacial endoscopic perforator surgery. And the fourth one is Trivex method. These are all the names of the surgery. We do not have to know in detail. Just what we have to know is that why this endothermal ablation is more preferred than the surgical method. It is because in case of surgery, what we are doing the greater saphenous stripping. We are removing out the greater saphenous vein. But just imagine if the patient is having any problem in the future, like he's having any cardiac arrest, okay, or any myocardial problem, and the patient need immediate coronary artery bypass graft, CABG. Okay, the patient need to be CABG, and if already stripping has been done, then the sural nerve is not present. Okay, the sural nerve has been removed. So in future, in order to prevent this sural nerve, okay, in order to uh, prevent this sural nerve from damaging, we do the endothermal ablation, that is EVLA and radiofrequency ablation, in order to preserve the sural nerve, so that if the patient can have any condition for which CABG has to be done, then we should have the sural nerve which can be used as coronary artery bypass graft. Okay, so in order to preserve the sural nerve, we prefer this endothermal ablation rather than this Trendelenburg operation. And the second condition is that this uh, endothermal ablation, it is the non-invasive procedure, not non-invasive, but it is less painful procedure, okay, than this Trendelenburg operation. And this EFLA and RFA, these are bit costlier, but their recovery and outcome is more good than this uh, surgical treatment. Okay, and one teacher asked that is there any drug which can be used for varicose vein? Yes, there are drugs like calcium dobisolate, calcium dobisilate, and diosmin. These are the drug which are used for varicose vein, but they are not used nowadays. Just the patient prefer to do this endothermal ablation or Trendelenburg operation. But endothermal ablation is it is preferred more, because in this endothermal ablation there is the preservation of the sural nerve, which we remove during this Trendelenburg operation. So this radiofrequency ablation or EVLA, it is preferred for the treatment of this varicose vein. And external ask one last question, that why this varicose vein is more common in humans rather than in monkeys or other animals. So this was a very tricky question for me, but the actual answer is that in case of animal, they are usually having the the two hands and two legs for their locomotion. Like monkeys, they use we are the bipedal organisms, okay, but these monkeys, they used to use both hind and forelimbs, uh, due to which the stress which we normally put in our lower limb is more than those animals. And also the uh, hind limbs, and also the hind limbs, they are in case of these monkeys, the hind limbs, they used to have a very thicker thicker tunica media. Okay, they have thicker arteries, and they are having they are having low hydrostatic column uh, in comparison to this human. Okay, so due to these reasons, they are more common in humans but not in animals. Okay, with this I would like to end this video here. If you have any suggestion or anything related to this video, or for the preparation of the next topic, let me know in the comment section. Thank you so much. Share this video to your friends, uh, like and subscribe the channel. Thank you.